Bismillah ar-Rahman ar-Rahim. Welcome in this new meeting, Egyptian Society of Nephrology and Transplant CME meetings. Today, we will discuss a topic, very important topic in kidney transplantation, how to diagnose issues and conditions in kidney transplantation using. Our speaker today is Professor Moataz Fathy, one of the very active member in interventional nephrology in Egypt, Arabic world of nephrology Arabic community, and international and African community. He is the head of interventional nephrology, our initiator of interventional nephrology center in Qasr Al Aini, and one of the very active member of interventional nephrology group, Egyptian Society of Nephrology and Transplantation. And I am to welcome our moderator today, Professor Fatina Fadel. She is Professor of Pediatric Nephrology, Cairo University, and she is the head of interventional nephrology chapter in Egyptian Society of Nephrology and Transplantation. And she is leading by position all of the activities of the Egyptian Society of Nephrology regarding interventional nephrology, workshops, talks, and conferences, and etc. So please, I will leave the floor to Professor Fatina to lead this meeting, and welcome Professor Moataz Fathy. And in the start, I am to welcome all our attending professors, Professor Ayman Rifai, Professor Hisham Sayyid, Professor Saeed Khamis, Professor Faisal Shaheen, and thank our coordinator today, Dr. Islam Abu Ni'ma, who is taking the job of coordinating this meeting. Thank you, and please, Professor Fatina.
Assalamu alaikum wa rahmatullahi wa barakatuh. I would like to welcome all of you, dear professors, and I hope that you will enjoy the coming talk by Professor Moataz Fathy. Actually, Dr. Moataz Fathy is one of the most active and the most clever in the field of interventional nephrology. He is Associate Professor of Internal Medicine and Nephrology in Cairo University, and he is the Interventional Nephrology Section Director in Qasr Al Aini. Today he's going to speak about imaging in kidney transplantation, case-based illustrations. Please, Dr. Moataz.
Bismillah ar-Rahman ar-Rahim. First of all, thank you all the attendees, Dr. Yasser Al-Hamid, the CME Director, Dr. Fatina, our dear Professor, Pediatric Nephrology. Thanks to all professors attending with us, all our professors, Dr. Saeed, Dr. Ayman Rafai, Dr. Hisham Said, Dr. Faisal Shaheen. Thanks for your participation. I'm very happy to introduce this presentation, which is case-based, to enter a new field of nephrology, to add some taste to nephrology and to present some ideas about how to deal with patients. Know that the transplantation is the treatment of choice in end-stage renal disease, and our patients are facing a lot of challenges to reach the point they reach the operating theater, starting from choosing the doctor, choosing the donor, dealing with labs and imaging, to reach the point, a lot of medical-legal aspects. There is some obstacles. You know that there is some people are adding these obstacles in our country, and the only source is a living donation. We had not yet deceased donor or cadaveric transplantation. I hope so. We can introduce this in the near future, because I think a lot of patients will have the ability to transplant. Also, if there any, the Egyptian Society of Nephrology can start a donation board in order to avoid all the people is not entering this market and so on. Thanks to all the attendees, and I'd like to start with a small hint about how to image our graft. It's now easier The conventional machine, you know, is changing. All the world is changing to deal with ultrasound. It's not no more a radiological point of view. It's a nephrological or clinical point of view to use like POCUS in all specialties. And now we have this small machine, wireless, can be used. It's very easy. You can connect it to our smartphones and adopt this technology in our clinical field. And this is our unit. I'm honored to be the director of intervention nephrology unit in Bahraini. We had so many attendees from all over Egypt that come to see and share and observe how to deal with minor interventions, catheters, central catheters at our unit on a weekly basis. Let's start with the imaging modality. You know, the most common imaging modality we know to examine our grafts is the color Doppler ultrasound. Unfortunately, we do have many operators to do it, but we in a precise way or to gain a good result, or you can see in the following cases that we are very misleading results that you cannot take a right decision. It's very easy to use the abdominal ultrasound, especially after using wireless machines. It's now in all transplantation units, all dialysis units. You can use it very easy. You know, this is the start of the ultrasound. Is the B mode. We describe the echogenicity, the cortical cerebral differentiation. If there are any cysts, if there are any calculi, if there are any to judge if there are any stones, suprarenal masses, if there are any stents. This is the B mode examination, and also Doppler examination. The kidney is a low resistant flow organ, like the spleen and the brain. All organs that receive blood from the heart are receiving it in a low resistant form. That the organ receives the blood in the systole and the diastole manner, and normal. This is a normal monophasic wave. Stiffity index means that the graft is still soft, is less than 0.7. You know, this is how I'd like to describe how the graft changes from a soft pillow to a hard stone. This change will affect the systolic flow inside the graft. So the peak systolic minus end-systolic over the peak systolic will increase the value of resistivity index. Resistivity index or impedance index means that the kidney resists the entering of the blood inside. And this occurs in stages. First of all, the diastole decreases, and then lately the systole. The cause of high resistivity index in the graft, as you know, is rejection, acute tubular necrosis, CNI effect, CNI toxicity, obstruction, renal vein thrombosis. You can notice the diastole here. This is high normal diastole in the left. The diastole is lost by time the graft is going to be stiff, the time the graft is having renal vein occlusion. There is a high CNI-FK level. There is an advanced ATN until you lose all these diastole and the wave started to reverse to be a triphasic wave, like the high resistant flow, like the femoral arteries, the external iliac arteries, all the musculoskeletal arteries. So it starts with this monophasic low resistant flow wave. This is an excellent wave, and ends with this triphasic wave, which means that the kidney changes its consistency from being like a sponge, like a pillow, a very low resistant organ, to a high resistant due to the causes mentioned in front of all of you. So resistivity index is the systole, the velocity of the systole minus velocity of diastole over the velocity of systole. Again, this equals the resistivity index, or how the kidney is going to be stiff. Okay, what about low resistivity index? A low resistivity index is a diagnostic of renal artery stenosis outside the graft, because the renal artery stenosis, we never have a stenosis here outside the graft. The wave the systole will be dampened like this. So the systole and the diastole will be near in values. And at the end of the day, you will have a low resistivity index value, which contributes to graft artery stenosis. There is another indices, which is acceleration time acceleration index, used to determine the velocity of the graft artery stenosis. This jet is never the artery be stenosed. If you have a stenosis, so like a pulsus talvus, you will have a slow upstroke of the systole, and this very slower. This is very severe stenosis. So at the end, we'll have a low value of systole, and the same in the stole. So we will have a low resistivity index. And this is a renal vein thrombosis. You know, the artery entered the kidney, and there is an entire diastole deflection of wave till the next wave, and this is a diagnostic of renal vein thrombosis, renal vein compression. This modality is being now, as you know, you can carry your tablet, you can carry a wireless machine. This is a conventional machine at our unit. What about intraoperative color Doppler ultrasound? This is, we assume this will be a novel job description for the nephrologist at OR. And under the provision of Dr. Fatina, the professor of pediatric nephrology, we are starting a campaign to implement this module inside the nephrologist, the job description of the nephrologist. That he can do, you can deal with the graft perfusion and so on, and also can use his machine, his personal machine, to estimate the graft vascularity. And this is the early pictures of the project we are dealing with at the pediatric nephrology theaters. We have done 2 or 3 patients up till now. Why we implement this module intraoperative? Because this decreases the quarrels between the nephrologist and the urologist. Because when you receive the graft by a Doppler, first of all, it's easy to return the patient, to open the patient, to do any reanastomosis, to estimate any surgical complication, especially if the kidney is anoric just after declamping. So the urologist will say to you, I have delivered you the graft, okay, and you received from me the graft intraoperative. Also, we can estimate some indices intraoperative. First diagnosis of ATN, you know, thanks to the ischemic time that increases the ischemic time that results in ATN. So can you diagnose ATN inside? So you say to the nephrology resident that the graft resistivity index intraoperative was so and so and so. So you can compare outside the patient get in the recovery room or in his room. So intraoperative graft ultrasound, we are now estimating its values in relation to graft rejection, in relation to surgical complications. It will be easy to redo a patient if there are any complications. And this is the wireless machine, easy sterilized. You can put this machine inside your gloves, and you can put the whole probe inside the wound, because you know the surgeons do not like always fear of infection, or patients are immunosuppressed. So the probes with wires will increase infection in the OR. So the wireless probe will be inside the gloves and will be easily used. Another imaging modality is color Doppler ultrasound with contrast. It deals with diagnosis of graft infarction. And this is a novel way is graft elastography. Elastography deals more with fibrosis, nothing to do with the early graft complications. If there are any chronic allograft nephropathies with a lot of fibrosis, so we are now dealing in a research about the elastography, its relation to EFTA, interstitial fibrosis and tubular atrophy, its relation to hemorrhage and bleeding. Is if a patient with a graft 10 years ago are going to biopsy this kidney or not. The elastography gives an info about how stiff is your kidney. It's easy to be palpated and easy to be done, especially the strain elastography. And this is a paper I have shared with my dear friend, Dr. Nadir Bersoum, the daughter of the late great Professor Dr. Rashad Bersoum. We are dealing with the shear wave elastography, and we have done some work now on the strain elastography. It may be give more some info, but we are dealing with a very hard circumstances that the ultrasound machines are not adopted and are not can do the elastography for the kidney. It can do it for the liver. They are having grading for the liver, F1, F2, F3, as you know, but we don't have any kidney modules. We can name it K1, K2, K3. We do not know. I have some workshops with different machine manufacturers, but we are now we have not yet any baseline to be to compare grafts elasticity with each other. So the papers are very hard to be published because we do not have a gold standard about what is this elastography deal with. So the most near is the EFTA. We are comparing the elastography to the EFTA. Elastography limitations, this needs a better training. Somehow it will be an accurate findings. We will see some cases. If there any gas, you know, our patients, anti-metabolites, MMF and CellCept and so are doing more and more distension. So the findings will be were not clear with the gas. Inability of the price of the contrast medium. We have no single research about ultrasound enhanced by contrast in Egypt. Elastography deals with the fibrosis. It's a chronic allograft nephropathy, have nothing to do with acute kidney injury and so on. Another modality is the CT and the CT angiography. It deals with arterial study, arterial anastomosis. Limitations of the CT to use the contrast material may need sonographic correlation. If you have any collection, you does not know if this this collection is septated or not, fluid, solid. Do not estimate graft hemodynamics, of course, endesis or parenchymal echogenicity, and not easily repeated. You cannot do the CT for the patient. Conventional angiography, all the past drawbacks in the CT, and adding the complication of intervention, puncture related to injuries, wires, and so on. And this is a modality is trying to be introduced in the CT angiography, is using the carbon dioxide. And the manufacturers of this apparatus are saying that, you know, at the upper part of the screen, they are introducing the carbon dioxide contrast. If we have a patient with an arterial study with renal impairment, elevated kidney functions, we cannot use the contrast if there any place to use the carbon dioxide-based studies. And this MRI and MRA, we do not need a contrast. Can estimate the renal vessels, arteries, and veins. And this is gadolinium enhanced MRI and MRA. And as you know, nephrogenic systemic sclerosis is one of the limitations. The patients cannot enter the MRI theater due to pacemakers, clips. The unavailability in a lot of hospitals, we do not have the MRI. It's expensive and not easily repeated. And this is the renogram mag. But it can easily estimate the function and the perfusion of the kidney and the function, but you know, it's non-specific often, and its images have really poor spatial resolution. So this in the last slide where we discussed the modalities that we have, and we are going in the second half of our presentation to present some case presentations. Unfortunately, we do not have time to stop after each case in order to have some or more question. So any one of you, please prepare a paper and number of the case. If there any question, because we're going to deal with the cases. We have 10 cases, okay, but if you are bored at some point, you can stop now, because we have too many. I have too many illustrations, so I've chosen the most. I see 10 cases can present in this webinar. Case 1, a 54 years old male transplant recipient discharged safely 1 week after transplantation with normal kidney functions. A few days after discharge, he is progressively oliguric, deteriorated kidney functions, 1.9 milligram per deciliter, readmitted for graft biopsy. So he is discharged and get back again due to progressive oliguria. He noticed, and they have done kidney functions is elevated and admitted, sent for readmitted for graft biopsy. Color Doppler ultrasound during examination during hospital in the routine examination was there is a small graft hematoma adjacent to anastomosis. And this is the re-examination of this patient. You know, this is the hematoma. Surprised by a flow inside this hematoma. And this is a characteristic through and through wave. And the kidney inside is ischemic. And this was the biopsy, the ultrasound before biopsy. So the intervention nephrology is saying that the image is more important than the intervention. You know, you must you must have an accurate image, have an accurate diagnosis before the intervention in order not to proceed to a kidney biopsy that enters that you do not know what is happening inside the graft, and you will be astonished with the biopsy results. So before the biopsy, the kidney is ischemic kidney, and there is at the anastomosis, beside the anastomosis, there is a wave called through flow and a wave, and there is a flow inside the hematoma that's noticed before the patient discharge, and this is called a pseudoaneurysm, a large pseudoaneurysm, and this is called graft steal phenomena. This is the iliac artery. This is the graft artery. This is anastomosis. You know, this is a leak inside the hematoma, and this is why the patient had no hemoglobin drop, no hemodynamic instability, and the blood that enters the kidney is not sufficient for maintaining a good urine output, and this is called pseudoaneurysm. And the wave, we put the cursor here to diagnose the true and the through wave. You know, the size of the aneurysm increases with palpitation, and again, it returns to its size. We have now two steal phenomena in nephrology. The first steal phenomenon we have in the fistula. We have a high volume functioning fistula, and this is a graft steal phenomenon you all should know and all diagnose. Unfortunately, it misdiagnosis of this case. So the surgical team meets the intervention radiology team. I don't need the visual nephrology. Intervention radiology team. The surgical team says that there is elevated kidney functions. We have a recent anastomosis, arterial stump. The transplantation was only 10 days ago. The intervention says that if we have normal kidney function, we use a contrast, and if we have availability of covered stents. The covered stents is indicated in these patients, which is not always available at our hospitals. And this is a covered stent between the iliac and the grafts put by the intervention radiologist, of course, not by the intervention nephrologist, intervention radiologist. This stent is covered like this, and this is an uncovered stent. Unfortunately, we do not have a lot of covered stents at our hospitals, which be the magic solution for this case. And if we do not have a covered stent, the intervention radiology offers coiling of this pseudoaneurysm. The drawback of coiling is the anastomosis the thrombosis occurs and pseudoaneurysm may approach through the anastomosis and the kidney may be ischemic. Decision is exploration because there was no covered stent available in the hospital. Exploration and reanastomosis in spite short arterial stump, in spite of very risk of heroic breathing when you open this pseudoaneurysm, but the decision was exploration. Case number 2, a 50-year-old male renal transplant recipient, unrelated donor, day 2 post-transplantation, progressive rise in kidney functions and oliguria, scheduled for renal biopsy inside his room. And this was initial graft ultrasound and Doppler. As you know, this is a low resistant flow wave, a normal diastole and systole, stiffed index 0.865. Okay, and this is the B mode ultrasound, normal echogenicity, normal size. And unfortunately, the biopsy was graft infarction. We deal with this case. I know a lot. We have a renal biopsy with a graft infarction, and the Doppler says that the perfusion of the kidneys is okay. What we should do in this? Please go back and revise your CT angio of your donor, because the patient may have an accessory artery or so. I know it's very difficult to occur, but please go back and revise your patient's papers. Maybe there is a missed accessory renal artery to be anastomosed or so. First of all, what about our graft? How we can image this graft? There is a powered Doppler module independent of arterial and venous flow. Can diagnose a part of this is an infarction of the graft. Part is infarctant, and the perfusion of the rest of the graft is okay. So maybe the sonographer, the clover needle, the operator needle had taken the biopsy from this part. I believe flow ultrasonography is a module offered by some machines. Can diagnose a part of this infarction. And this is the color of the B-flow ultrasonography. It's like an angio, but not so perfect in some cases. And this is the new module of these machines. You know, you can more and more easy diagnose a graft infarction. This graft has no filling defects. And as we said before, Dr. Yasser? Okay. The B-flow ultrasonography offered by some machines. It's developing until this clear image of B-flow module that can precisely adjust if there any part of this infarction, subcapsular, interlobular part, arcuate part inside the kidney or not. And this contrast enhanced ultrasonography I've never used, unfortunately. It's combination between the power Doppler and use a microbubble technique to be injected peripherally. Proceed to a case 3, a 45 years old female, day 8, post-transplantation, still admitted, progressively oliguric, non-declining kidney functions, routine post-operative ultrasound was free, bouts of uncontrolled hypertension. So the patient was admitted in hospital post-transplantation and is not just discharged because of her uncontrolled hypertension and non-declining kidney functions. To refresh, this is the image of the normal systole, the systole, a low resistant flow image. This is a normal kidney. This is normal kidney by ultrasound. This is normal kidney by Doppler. Renal vein is patent, and this is the normal renal artery. Our patient ultrasound, the safety index is 0.5, patent graft vein, stent in place, no collections, average size and average echogenicity. And after repeat the examination, this is the low resistivity index less than 0.5, and acceleration time increases more than 0.7, accelerated index decrease less than 3 meters per second square. Diagnostic of graft artery stenosis. So low resistivity index, high acceleration time, low acceleration index. The three signs are diagnostic of graft artery stenosis. If you found any report with a graft artery stenosis and a high resistivity index, so it's a fake report, or low acceleration time or high acceleration index, so it's fake reports. Low resistivity index, high resistivity index and graft artery stenosis don't mix. How to proceed in a patient with a recent anastomosis with a stenosis, significant stenosis that result in still high kidney functions and bouts of uncontrolled hypertension? Could the patient get back to surgically re-anastomose or proceed with the intervention? The surgical team says we have 2 risks of anesthesia and reoperation. We have a bout of severe hypertension. Our patient will not be stable inside the OR. The arterial stop remnants may be small, that we can do a re-anastomosis. The kidney is just emerging from an ischemic time, which may be long. So it will be another ischemic time, may affect the kidney life. The intervention team says we can do balloon dilatation with or without stent, but we all have contrast. Please predict our contrast score. Some intervention radiologists are not expert enough to enter the anastomosis. It needs operative details from the surgical team. We need its side-to-side anastomosis, its end-to-side anastomosis, and the most important thing is we have a fragile anastomosis. And this is an MRA of the renal graft with a stenotic artery. You can see the internal iliac artery, and this is the start of the graft artery. Almost there's attenuated flow. And this is the MRA of the graft artery. This is anastomosis, by the way, and this is a graft artery, and almost there is no flow inside the graft. It's right iliac graft. So conventional angiography is decided. Can carbon dioxide contrast help? And this is the site we can discuss. Can we use the carbon dioxide contrast can help in this part. And at the right side, we do have this stenosis, and this after correction. This was by the intervention radiology team, by the way. Okay, unfortunately, after the intervention, the patient experienced deterioration of hemodynamics, oliguric, hemoglobin drop, rising kidney functions, and start dialysis. This was a fragile anastomosis. When you are going to cannulate a fragile anastomosis, this happened, a hematoma, a sizable hematoma, with hemoglobin drop and oliguria. And the patient finally was in need for dialysis. What is the next step? Is to surgery, is to do we explore the patient with this large hematoma, or to leave the patient conservatively? First of all, We can do a serial color Doppler ultrasound. We think that this is life-threatening bleeder, mostly lost graft. If we open this patient, we'll do a graft nephrectomy. The conservative ideas was thanks to the local tamponade of this hematoma. If there's no hemoglobin drop, if the hemodynamics is stable, so we can conserve on these patients. In order not to open this hematoma, we can lose this tamponade. The artery may be, the blood loss may be heroic, intraoperative, and ends in the graft nephrectomy. The decision was conservative, and thank God the graft stent was what was done was by the intervention radiologist. The flow started, the perfusion started again, and the kidney was perfused and discharged on the baseline creatinine. I don't remember 2 or 3 milligram per deciliter for follow-up. Passing to case number 4, day 0 renal transplantation, progressive oliguria, then complete anuria, pain and tenderness over the graft. Graft ultrasound and Doppler. You can see this wave. This is a total diastolic deflected flow, deflection the wave. This must be here over the line because the blood goes in unidirectional during systole and diastole. So there is something inside the kidney that repels the entrance of the diastole, and this is a diagnostic of renal vein thrombosis. How to proceed? Anticoagulation. Is there any role for the interventional team with the graft vein thrombosis or re-exploration? You see, you must diagnose renal vein thrombosis. This is the wave of high resistivity index inside the graft, maybe ATN, maybe CNIs, maybe obstruction, and this is a diagnostic of renal vein thrombosis. You know, this deflected wave, small wave, and this the whole of till the next systole, diagnostic of renal vein thrombosis. Why you must decide? How must diagnose renal vein thrombosis? Because of this slide. What is going to happen if you biopsy this graft with missed renal vein thrombosis? The bleeding will be heroic. Major bleeding complication. The blood found way out. The blood enters from the artery and hits the vein, closed vein. So the graft is swollen, tender. That's why the patient have a tenderness over the graft. The graft may rupture. The bleeding is non-stop. Subcapsular, the graft may rupture. If it's out, the patient may lose his life. So a diagnosis of renal vein thrombosis must be ruled out before graft biopsy. Even you cannot hemostatic control this patient because of tenderness over the graft. You cannot compress over the skin of this patient. And the intervention, it's not the intervention is the only way, maybe the only way to stop this bleeding. So please, before biopsy, be sure that there is no graft vein thrombosis. And this is a case of post-transplantation vein thrombosis, successful surgical thrombectomy, and review of the literature. Surgical exploration is the management of choice of renal vein thrombosis. And this is the picture of the thrombus. And this one of the benefits of intraoperative Doppler, if we're going to have a renal vein thrombus or a poor wave in the renal vein, you can re-explore the patient and re-anastomose the patient or get the thrombus out. Case 5, a 19-year-old female renal transplant recipient. Donor was identical twin. A very good transplantation. Day 0 hemoglobin drop and progressive oliguria, no decline in kidney functions. The first day of transplantation, the patient experienced hemoglobin drop. Bedside sonography, at first, diagnosis perigraft hematoma and average size the graft. to refresh, and this is a normal wave of the kidney, systole and diastole, and this is a low resistant wave, and this is the normal picture of the kidney to refresh. What happened to this patient? Our patient with hemoglobin drop, this is the normal wave, and this is the wave. Oh, this is diagnostic renal vein thrombosis. So a diagnostic renal vein thrombosis at first was made. We called the surgical team. We do have renal vein thrombosis. And then during ultrasound reassessment, we found that there is a graft compression. This is a hematoma, subcapsular hematoma. The capsule is stretched. The pain, the patient had a pain over the graft. It's like a renal vein thrombosis, a typical the last case. But by grayscale ultrasound, we found a graft compression by a tamponading hematoma. And the renal vein is giving the same wave as if it is thrombotic. And this is a CT scan of the subcapsular graft hematoma. Urology team consultation, likely lost graft. Maybe a role of intervention for intervention. The graft is tamponading. If we lost this tamponade, we'll have a rowing bleeding, and maybe a possible nephrectomy. Why there is no a place for intervention in this case? Because pigtail in organized hematoma will not drain this. And if the hematoma is non-organized, will break the tamponade and may rebleed. But the pigtail may induce infection in this situation. So no place for intervention in subcapsular hematoma early postoperative. And Doppler says the same wave diagnosing renal vein thrombosis is the renal vein compression. Why not to re-explore this patient and give the patient a chance, especially they are identical twins? The decision after pressure from the nephrologist to reoperate this patient. Simply, this was a hematoma, subcapsular, opening the capsule, subcapsular hematoma evacuated, renal vein was patent, just compressed, and urine started intraoperative. Proceed to case number 6. A 34 years old male renal transplant recipient, unrelated donor, discharged post-transplant day 6 with normal kidney functions. Day 16, progressive sense of distension and lateral lower limb edema, no urinary complaint, rising of creatinine 1.1 to 2.1, and sent for biopsy. By the way, this patient was having a tight style stent. What's meant by tight style? That the urologists have tied the stent inside with the Foley catheter in order not to reoperate on the patient with cystoscopy to remove the stent. The stent will be removed by the urinary catheter once the urinary catheter is removed. And this patient was requested for biopsy. The patient was having an unilateral lower limb edema at the right side, mild abdominal distension, normal FK level. Bedside Doppler was free of his lower limb, and the graft ultrasound and pelvic Doppler diagnoses a collection beside the graft. This is the collection. This collection was compressing the iliac veins. This was the cause of unilateral lower limb edema. And this is a CT scan, a hilar graft encysted collection with compressive manifestations. Compressing the graft ureter, compressing the urinary bladder, compressing the iliac veins for contrast study. And unfortunately, we do have a high kidney function. We proceed to sample chemistry of this collection, the creatinine 33 diagnostic of urinoma. How to proceed with the urinoma? Can we do a cystoscope and stent insertion? It's not an easy, by the way. Pigtail insertion and drainage of this collection. Graft nephrostomy, but the risk is that it's not hydronephrotic. There's no back pressure. that you can enter your pigtail or nephrostomy tube easily. It's a high risk. The decision was ultrasound-guided graft nephrostomy. Nephrostomy, not drainage. Why we do not drain this urine? Because urine intervention through the drainage tube. The urine will be diverted through this pigtail outside. Use this as a diagnostic tool and source of infection. This pigtail may introduce infection inside the patient. So drain this urine and remove hit and run technique. And after graft nephrostomy, we can proceed to antegrade pyelography to diagnose where is the stenosis or the leak of urine in the graft ureter. This is a urinary bladder. This is antegrade pyelography. In addition, you can use, this is virology. The virology, by the way, you can introduce a wire inside this graft ureter and restenting of the graft. So if you want to do the stent via cystoscopy, it's very difficult to enter this from here. You can maybe out or injure the ureter, but antegrade via antegrade is easier. How to drain abdominal urinoma? We can use single step pigtail or multi-steps. And this is Dr. Ahmed Halawa from England that shared in this paper in the literature how to deal with a urinoma. If it's large, a urinary leak, it's better to be reoperated. If it's smaller, you can drain the urine out and try graft nephrostomy and antegrade pyelography as a correction of the choice of this urinary leak. Why this urinary leak had happened from the start? I think the tied up stent, the anastomosis is not well established. So when you remove the stent 10 days or so after transplantation, there may be a urinary leak from the anastomosis of the graft, vesiculoreteric anastomosis. Proceed to case number 7, 50 years old male patient, day 7, renal transplant recipient, still admitted, anoric just for post-urinary catheter removal, tied up stent technique also. The stent is tied up the urinary bladder. After removed at the day 7, the patient became anoric. Graft ultrasound and Doppler. There is a high resistivity index due to renal vein, obstruction of the graft. And this is hydronephrotic changes, moderate ballooning of the pelvic health system, and this is a low diastole. So resistivity index increases 0.82. Technically, it's easier to proceed to graft nephrostomy in a hydronephrotic graft. It's technically easier. It's very difficult to do it without hydronephrosis, like patients with urinary leak at the last case. But this patient will be easier. So when we do a bladder ultrasound and so we don't find the stent is out. So originally the team proceed to fluoroscopy guided graft nephrostomy as it's easier. Okay, let's deal with this paper published in 2016 about tying up this stent. What about tying the stent to the Foley's catheter or leaving the stent to be removed endoscopically after 3 weeks later? Okay, if you want to do this tied up stent, the stent was simply removed by taking out the Foley's catheter after 3 weeks. So if you are tying the stent to your patient urinary bladder catheter, please do not remove the catheter for 3 weeks. And in our 2 previous cases, the catheter was removed 1 week or 10 days only. So it's nice to do it in order not to reoperate the patient or do another surgical intervention and not introduce infection. Okay, it's okay, but leave the urinary bladder catheter inside the patient for at least 3 weeks post-operative. Case number 8, 27 years old male patient, renal transplant received 7 months ago. Fair urine output, indicate failure biopsy due to rapid deteriorating functions. Graft ultrasound was normal. Renal biopsy done. The patient was unable to urinate. And this is the advantage of being a sonographer after transplantation biopsy, after transplant biopsy. You can demonstrate the blood, the pelvic cell system, turbid blood. Renal bladder ultrasound. Patient is having a blood clot in the bladder. This is why he's not able to urinate. Urology consultation, admission, 3-way catheter insertion with bladder irrigation. And this is different technical approaches to avoid medulla to decrease bleeding. Is this some biopsy complications? Fistula, perigraft hematoma, subcapsular. Case number 9, 30 years old male patient, renal transplant day 10, feverish and rising functions. Biopsy required by a training physician. So we have the patient is after discharge back with fever and rising functions, biopsy required by training physician. The graft ultrasound and Doppler was normal. But during examination, the patient is having this cutaneous cellulitis, but cobblestone appearance. And this is imaging of the infection. And this may be the cause of fever. Cutaneous microabscesses like carbuncle. So don't forget our patient is immunosuppressed. And this is social line may infect. And this infection may proceed to somehow rise of the kidney functions. Do not rush to biopsy in a patient with infected skin. We're going to transfer this infection from the skin to inside the graft. The loaded needle with pyogenic contact. And this is another site of infection. You know, all the patients are explorated for psoas muscle. So it may be a psoas abscess. Must be excluded before doing biopsy, so the ultrasound can diagnose psoas muscle abscess after transplant. And this is a drainage of pus of the psoas muscle by percutaneous intervention technique. I hope these cases and this presentation was illustrative to you all. At last, I'd like to thank all the organizing committee of this nice meeting. I'm sorry for being fast. I'd like to show more than cases, more than illustrations. I'm happy to hear your questions, and thank you.
Thank you, Professor Moataz, for this very comprehensive talk. We have many comments from professors. And Professor Fatina, please.
Thank you very much, Professor Moataz, for this very informative and illustrative talk. Thank you for the very interesting cases with the intervention, whether surgical or radiological. So thank you very much. And we open the floor for the questions.
Professor Ayman Rifai wants to comment, please.
Yes, thank you very much, Professor Moataz. Very interesting and challenging cases, actually. I have some comments about some points. Should I receive the answer of each point, or should I raise all the points and receive the answer at the end?
I will answer point by point.
One by one? Okay.
Okay.
Of course, the shear wave elastography is a good modality for diagnosis of the transplant fibrosis. Even it's applied now for non-transplant in CKD to detect the fibrosis. I think this is a good modality, and sometimes it may eliminate the rule of graft biopsy in cases with IFTA. Actually, I have some concern about, you mentioned there is a study of routine intraoperative Doppler of the graft, right?
Yes.
Yes.
No,
I
it's
don't
starting a
know
campaign.
I don't know what is the value to have this in a normally perfused graft showing good urine output, and everything is okay. I think we need this intraoperative Doppler study in case of anuria, in case of soft graft. We are not happy with the perfusion. Otherwise, what is the value to have this early information intraoperative? If you need to have a basal, you can have it in the recovery room, in the ICU later on. I mean, what's the value to have intraoperative color Doppler or Doppler study in well-to-do graft? What's the
Okay,
rationale?
thanks for this question. It's first of all will be for the surgical complications. We have experienced hematomas, renal vein thrombosis, migrated stents, and I think it's for surgical. It's with to stop the quarrel between the urology team and the nephrology team. I agree with you. In the nephrology perspective, that we do have a high resistivity index in most patients. So in our study, I think, but it's a naive result that we do a high resistivity index thanks to the ATN. So if you hear that the resistivity index of your patient is high, intraoperative or early in the recovery room, do not be afraid or so. It will normalize by time. I think this is the point. And it's the first time to be done this intraoperative Doppler. So we are going to take all our what we can estimate inside the OR and get out the patient and compare this indices with the discharge indices. But you are right; it's surgical concerning complications in the first place.
Okay. Case number 3 with the renal artery stenosis. I think there is a rule that if we have renal artery stenosis, is it recent or old transplant? I think for recent transplant, it is not wise to go for intervention. Otherwise, the complication that already happened in the patient, you are going to give a dye, the patient is heparinized, there is still fresh anastomosis, not healed yet. So in renal artery stenosis, early post-transplant, I think surgical and revision of the anastomosis is the most advised. But if we have a transplant for a year, or more than a year, we can perform balloon dilatation and go for intervention. So I think the decision of intervention in a recent fresh transplant is not wise, because as it happened in this case.
Yes, I do agree with you. The stenosis was fragile, but the surgical team was not able to do a reanastomosis. They were saying that the arterial stump was not okay, and we are going to lose this graft. If you can wait for 1 week or so to do this intervention or balloon dilatation or so, as you have mentioned, it will be better. But the patient was having bouts of hypertension, non-declining kidney functions, oliguria. So in the urology team didn't accept to re-enter the patient the operation theater. So the patient was proceeded to the intervention, and as you said, this is a fragile anastomosis. I have mentioned this presentation, and this hematoma was I do present a real cases, Dr. Ayman.
Yes,
and
I know.
And this was a big hematoma.
Real life case scenarios. Yes,
big hematoma.
But I think this is a good lesson that we should not touch the anastomosis, a fresh anastomosis by intervention. It's better to be explored and redo.
Be explored and redo, but the surgical team if they have a bad history with this patient, that they have damaged a small arterial stump and so they push the intervention team for doing intervention balloon dilatation, and this was a real case. Yes. I do it ultrasound, serial ultrasound for her. So I present this. What had happened precisely is mentioned. Thanks, Dr.
Okay, thank you. Case number 4, the graft vein thrombosis. I think there is a room for the intervention via injecting streptokinase. We did it several times through the contralateral femoral vein and approaching the cannulating the vein and injecting streptokinase, and they are doing well. I mean, it is not necessary to explore in such cases. We have to try first thrombolytic therapy. If failed, we can explore the patient. So I think this is
but the surgical team always object on injecting a TPA in a patient with we are saying that we have few hours ago we have just closed this patient arterial anastomosis. The drains are, we have 800 serous angulus in the drains. So as you mentioned,
excuse me, this was a recent transplant?
Yeah. It's already
okay. I agree. I thought that this after a while we can perform this TPA.
Thrombosis, yes, always occur in the early transplant period because the stitches in the vein may induce thrombosis. As you know, it's not a high jet flow like the arterial. It's a venous flow. It's very fragile for getting thrombosed. So getting back the patient to OR in the early transplant is better because the patient is having a lot of drains, some hematuria, the suture line is oozing blood, and so on. Thanks to Ayman.
The last comment about case number 6, the case with after removal of the, I think the practice of tying the catheter to the double J or the stent is a risky maneuver, actually. A lot of complications. The least is the urinary leakage, but you may find a hematoma that compressing the veins of the lower limb, compressing the pelvis, like the other case. So I think the removal via the endoscopy after 2 to 3 weeks is safe, and the endoscopy is a very simple procedure. It is not a surgical procedure like always mentioned, and to remove it safely. But removing the tied catheter with the stent blindly in a fresh uretrovesical anastomosis always or frequently complicated with urinary leakage. So we are not practicing this.
I agree with
and
you,
as the paper
after 1 week.
Yes, no. It's minimum 2 weeks to remove a stent.
Yes.
As the paper said, the article you presented, that minimum 3 weeks to have safe practice. But generally, this practice is not advised. The removal with the endoscope, simple cystoscopy, is better. The other thing that managing the leakage after you did a great job by doing a nephrostomy tube, because some may argue about the re-exploration and revision of the retrovesical anastomosis. So I think putting a catheter at the nephrostomy tube, as you said, it's hard in a collapsed pelvis. There is no back pressure.
Leaking urine,
it needs
difficult.
Very difficult, and you can judge by the antegrade pyrography. Is this leakage site is large or small? If it's small, you are going to put a double J stent antegrade and with a urethral caster and leave the wound, the anastomosis to heal. But if this complete avulsion of the retrovesical anastomosis or the site is the site of leakage is large, I think it should be explored, and this is the
Thanks,
the
Ayman.
rules
I'd like to add للأسف, unfortunately, we do have a financial issues with re-enter the patient with to remove the stent. I'm so sad to say this, but
Yes,
actually,
this is a problem. This is the problem.
this
Yes,
is a problem.
yeah. This
You
is
know,
the only
the problem. The
reason.
urologist
Yeah, I know.
is trying to minimize the risk, the financial burden on the patient. So he's going to say to him, go with the urinary cath and get back after 1 week or 2 weeks. I will get the catheter out. The re-exploration in the patient with the urinoma, the surgical team always resists this because the urine causes an infection, the peritone, an infection on the side of anastomosis. So they say that if we're going to do an anastomosis in a leaking urine in these circumstances, any stitches will not heal. So try to do nephrostomy in a collapsing graft, which is very difficult, image by anti-grid pyelography, and trying to do a stent. I do this with my colleagues of intervention urologist, that I do the anastomosis by ultrasound because it's very difficult to do it by fluoroscope alone. You must see the tip of the needle inside the peripheral cell system, and I inject some gel or some fluid to do an artificial back pressure, Dr. Ayman. And this is how I do it in the intervention theater. After this, my colleague of the urology team enters a guide wire within this back pressure I have done, within this nephrostomy, and trying to image if there is a large tear or a small tear, or this guide wire can be directed to the bladder. And in some cases, we do have a cystoscopy in a concomitant use in this time. He can, the cystoscopy can manipulate the wire. And after that, we the urology team do anti-grid stenting through this wire. Thanks, Dr. Ayman, for your observations. It was very helpful and illustrative. Thank you.
Thank you. Thank you, Professor Ayman, really for illustrating these points, especially the point of necessity of removal of the catheter cystoscopy. And again, this is the common practice of removal of the catheter nowadays yearly and not endoscopically. Professor,
but I think, Dr. Yasser, that in transplantation practice, if we consider always the cost, we will not do an ideal transplantation practice. If I don't have IVIG, I don't have the facility to remove the catheter with the endoscope, I don't have immune suppression, I think either doing a perfect transplant with all its costs or not. I mean, halfway is, this is my opinion. Thank you.
Agree with you.
Yeah,
totally agree with you. It is a costly procedure, and we are not to play a costly procedure without having the cost in advance.
Yes, of course.
Yes.
Thank you very much. Thank you.
Thank you, Professor Ayman. We have Professor Hisham Said and Professor Faisal Shaheen. Please, Professor Hisham.
Thank you very much, Moataz. I very enjoyed. It's a huge science inside and technicality. And Professor Ayman for sure covered a lot of questions and by his experience in the field. So I don't have anything to ask about after Professor Ayman had raised a lot of questions, but I am still here from my position. I am raising up because we can have as well experience from Professor Dr. Faisal Shaheen. With Professor Fatina and Ayman, what is the legal point for nephrologists for intervention? I am talking about intervention nephrology in permicase and other. We talked about that, but still in Egypt, we don't have a GD experiences to give the chance for all nephrologists. Probably from complication, we know a lot of complication can happen from anyone, from the surgeon, from the vascular, or even from intervention based radiology. But on nephrology based, we have to do something.
Yes, of course, Professor Hisham, this is a very important point. We are trying to legalize this part of work, the interventional nephrology, how to be legalized. I think this is the rule of the society.
Yes, but society, you know that society, we discussed that before, and we put a rationale for that. but actually we cannot give a license. So what do you think to move? I understand it's beyond the science, but it should be discussed later on a
Yes.
base of a community based, and probably we can have an experience from other countries like Saudi Arabia or other countries. But I think a lot of to do with nephrologists who are interested in intervention nephrology by doing a certificate of approval or something like medical legal approval from anywhere.
I think this
Professor-
should start. Yeah. Do you have any comment, Professor Faisal?
Yes, I think Professor.
Professor Ayman? Yes.
I
Yes,
think we
please.
have to separate between two things in intervention nephrology, Professor Fatina. In nephrology practice, in creation of the fistula, vascular access, etc., Tinkoff catheter, etc. But with transplantation practice, the rule of nephrology intervention, I think, it is limited, and the responsibility is always on the surgeon and the intervention radiologist. So I think going
Yes.
In this dilemma will be
Yes.
by the nephrologist is risky. I think
Yes.
we have to legalize the in case of the renal replacement therapy, whether hemodialysis
Which
or
is the
peritoneal
commonest
dialysis.
techniques used.
Yes, but entering the nephrologist in intervention of a transplant kidney, I think it's better to be away the nephrologist in this dilemma,
Yes.
because this is a lot of responsibility, and these are usually surgical complications that should be the responsibility and solved by the surgeon or the well-trained intervention radiologist. So I think it's
Thank you,
better to be
Faisal.
away
I'd
from
Needs to be
like
this.
to
thorough.
comment. I'd like to comment, Faisal.
Needs to be thorough.
Thanks for your comment. I'd like to have a small comment in nephrologist. I do urge that we do have the diagnostics, to be sure
Yes,
with our
of
diagnostics.
course.
We want our nephrology resident, if he is responsible for a transplant by a night shift, that he can use his wireless ultrasound or a bedside ultrasound to diagnose renal vein thrombosis, to
No
diagnose
worries,
renal
no
artery
worries on diagnosis. No worries.
This
No
is
worries on
why
diagnosis.
Of course.
diagnostic more than intervention. I mentioned in most of cases that the pigtail insertion is useless. The pigtail insertion is nonsense. The only intervention I perform in the transplant is the nephrostomy, and I do have a urology team beside me, and they are not doing it ultrasound guided. It's very rare to find a urologist that do ultrasound guided nephrostomy in a collapsed lung. But I do it. Why? Because I do a lot of renal biopsies, so I know the needle tip inside. But to avoid injury the zerota fasciis, to avoid injury the segmental arteries, I do have urology with me for legalization of this part. Another point of intervention, I do push all our nephrologists to be diagnostically okay, to be to attach to insert temporary and or permanent catheters to do anal biopsies. But after 12 years of intervention, I can say that the endovascular techniques better to be avoided by the nephrologist. It needs a lot of years of experience. It needs it will not be trained easily. And I think mainly intervention nephrology deal with diagnostics, ultrasound and Doppler, and how to read the MRI, how to read the CT, and so.
Thank you.
And do the simple short-term, mid-term, long-term catheters and perform anal biopsy.
Thank
Very
you for
wise.
this heavy. So thank you, Moataz, and thank you, professors, for this heavy discussion. And back to our meeting, Professor Faisal Shaheen, please.
Thank you very much. I enjoyed the talk and the cases actually, because this is the real cases which we can see post-transplant. I will rather comment about my friend Professor Ayman about keeping the fluid with the stent and remove it together. It is mainly because of many patients are very poor to be admitted again and to pay a lot of money in order to remove the stent from inside. In my own practice now, I have one case only, partial leak and probably out of 100, there is nothing happen at all from to keep the stent and remove it with the Foley's catheter. The other things about the invasive nephrologist, now in Saudi Arabia, we have fellowship in invasive nephrologist, which he can do all the procedures. I will tell you frankly, at the end, he will work as a nephrologist because he will be very busy to go to radiology and to do any stent or something. But he is qualified as invasive nephrologist and being certified from the Saudi Commission that he is an invasive nephrologist. So, and he can perform all of this in any hospital. So, again, at the end, we will end up to just give the cases to radiology, to probably urologist, to probably the transplant surgeon to do his job, and we'll be away as a nephrologist because we are so busy to go and do such things. Thank you. This is my thanks for the talk. It's excellent talk.
Thank you, Professor Faisal, for this comment on illustrating your experience, heavy experience in Saudi Arabia. We have Professor Saeed Khamis, please.
Thank you, Professor Yasser, and thank you for all professors. Thank you, Professor Fatina, Professor Moataz. Actually, I would like to ask the same question of Professor Hisham from the legality of, or the medical legal point of view. Even the Bermicas, it is not allowed for the nephrologist in Egypt. I mean, because it should be done in ER, either removal or insertion of the Bermicas. But anyway, it is a long story, and you know, it needs persistency or for asking of this from the medical legal authorities and so on. My question to Professor Moataz: what is the specificity and sensitivity of this resistive index? Because I see, okay, it has its value in limited situation, but you see, you mentioned many differential diagnoses in this high resistive index. So I saw in the in most of the reports of the radiologist, they focus on this pulsatility index or resistive index. And if it is high, I think it is not of value or great value to diagnose a specific disease. Once it is either ATN or CNI toxicity or acute rejection, all these are the differential diagnoses of graft dysfunction. So what is the value of this? Apart from if it is low, it denotes renal artery thrombosis or whatever. This is my question, Professor Moataz. Thank you.
Right. Thanks for your question. The resistivity index is a broad, its broad definition is to diagnose, if it's high, to diagnose renal vein thrombosis, as you said, CNIs, if it's high. But if it's low, it's resistivity index. What about if it's normal? I think it deals with the graft hemodynamics. So when you add the nephrology science to the operator, it will end in at least to expect what is diagnosed gonna be. So if you have your patient in the day 0 or the early, you are expecting that this high resistivity index will decrease by time, and everything will be okay. If you have resistivity index normal, this is a big research that are working on now. That what about if you have a graft, a high kidney functions with a normal resistivity index? And this is a research I'm doing now, and my early findings are being that there is maybe some sort of graft infection that is having the higher part of the diagnosis. So when I have resistivity index low, I'm saying that I'm dealing with a resistivity index, graft artery stenosis. Sorry, when I have it's high, we're doing some diagnoses. We have when you have it's normal with elevated kidney functions, I somehow expect that maybe there is an infection. Not precise. I must do research on this, and we have some theses. 2 theses at our Qasr Aini are dealing with the normal resistivity index values, that dealing with infections, BK virus, CMV virus, pyelonephritis. We have a creatinine, a very high creatinine with normal resistivity index may point that this is infection, but a precise infection never. The resistivity index will not replace the biopsy, but it adding this info to the nephrologist will add a diagnosis or expecting will narrow the differential diagnosis of this patient.
Yeah, so it is a matter just of screening rather than a diagnostic tool,
Yes.
as you mean.
Yes.
Okay, thank you, Prof. Thank you.
Thank you, Professor Moataz. Thank you, Professor Fatina. And we have no more comments and no more questions. And please, Professor Fatina, can we close now?
Thank you very much. Thank you, Professor Yasser, for this highly organized meeting. Thank you very much, Professor Moataz, for the very elegant and informative talk. We all enjoyed it. Thank you for all the professors who attended, and looking forward for meeting you again and again. Thank you.
Thank you, Professor
Thank you.
Fatina. And thank you for being with us and for leading this meeting. And thank you, Professor Moataz, for your highly illustrated cases, highly illustrated cases, and for this very interesting time in this meeting. Thank you all professors who attended the meeting, Professor Ayman Rifai, Professor Shams Sayyid, Professor Saeed Khamis, and Professor Faisal Shaheen. And excuse me to close, I'm announcing about the coming session, which will be by Dr. Tariq Ashur from Cleveland Clinic in association with Professor Wissam Ismail, Professor of Pathology, which will be clinical pathological meeting about kidney amyloidosis, what's recent in kidney amyloidosis, especially in the treatment. See you next Wednesday, inshallah, 9 p.m. in our usual time. تصبحوا على خير والسلام عليكم ورحمة الله وبركاته.
عليكم السلام. السلام عليكم.